Hello, everyone. Good morning and welcome to today's ADAA professional webinar, providing psychotherapy to Black and African American clients. We have a wonderful session here today with Dr. Turner. Thank you to everyone for joining us. Please feel free to introduce yourself in the chat for those who are joining us live. I would like to introduce our presenter. Dr. Earl Turner is a licensed psychologist, professor, and owner of Turner Psychological and Consulting Services. He is a nationally recognized speaker, consultant, and mental health expert who launched Therapy for Black Kids, which provides mental health tech support and psychoeducation resources to help parents raise mentally healthy kids. Dr. Turner, thank you so much for joining us today. I'm just going to go ahead and hand it off to you.
Perfect. Thank you so much. I'm excited to be here today to share with you on this particular topic. So give me a couple of seconds to get my slides up. All right, so hopefully you can see that now.
Looks great.
So I'm going to be speaking with you about providing psychotherapy to Black and African American clients. And I'll talk a little bit later about why I wanted to really be intentional about including both of those sort of ethnic and racial identities here. But I do think that we need to really be intentional about understanding those two distinctions. So just a disclaimer, I have published a book, Mental Health Among African Americans, and wanted to note that I may receive royalties for this book. And some of the content that I discussed today will be in relation to information that I shared here. So these are the learning objectives for today. I'm sure that you've read them, so I won't read them verbatim, but I hope that by the end of today, that you will be able to improve your understanding about how to improve your working with diverse populations, specifically those that identify as Black or African American. So just a little bit of background. I think that for most of us here today, we have some understanding about the severity of need in terms of understanding mental health use within the United States. If we look at the data and statistics, we understand that over years, there have been disparities in terms of use for underserved and marginalized populations. And comparing that to general demographics within the US, we note that about 1 in 5 adults in the US and about 1 in 6 youth have a diagnosable mental health condition. And so that's not considering those that may have some concerns, but sort of don't meet that threshold in terms of the diagnostic criteria that we look at with the DSM. However, among individuals from racial and ethnic groups, we continue to see for years that there are rates of underutilization significantly lower than average. And this is a particular concern because we know that having this higher unmet need can also lead to additional sort of challenges in the person's life. Another consideration that comes up often in relation to understanding some of these disparities is that financial considerations may or may not contribute to why we continue to see this, this decreased use among this population. And so there are some studies that look at individuals who have health insurance, for example, and does that improve their ability to access care. And what we see is that that doesn't always predict individuals utilizing the services. And so despite having insurance that covers mental health treatment, individuals still may not access or have the ability to access services. And there may be a variety of reasons for that. But I think that's important to discuss because sometimes I think we believe that financial considerations are the sort of most important factor that may contribute to whether someone seeks services or not. And so for me, this topic has been something that I have done research on and worked with for a number of years since I was in graduate school. And a big reason about why I really became passionate about this topic is really understanding, what are these other outcomes that may be impacted in terms of our mental health. And so if we look at the literature, we know that for individuals who have mental health difficulties, it may impact their school attendance and performance, particularly if we look at youth, that youth may have some behavioral challenges that may result in them being missing days from school or getting suspended due to some behavioral challenges. We know for adults, it could impact employment as well as productivity in the work environment, especially when we understand the role of stress for many individuals and how that may contribute to potential burnout when they are under huge demands under those settings. Additionally, we know that mental health problems also impact relationships as well as physical health. And so there's a lot of research that really talks about for individuals who may experience some mental health challenges, that it oftentimes makes it difficult for them to also cope or manage chronic health conditions. So obviously there are a lot of factors that may be impacted by mental health. And so we do want to understand what are the ways that we can increase access, as well as understanding what may be some additional challenges for those individuals once they are actually in our offices. So I am a pretty data-driven person, and so I like numbers and graphs. And so I like to share a little bit of data in terms of looking at this disparities in treatment. So this graph is a couple of years dated. They actually stopped collecting some of this data a couple of years ago, but I still think that it's important to understand where the trends are in terms of looking at treatment use. This particular graph here is looking at adults across racial and ethnic groups. And what you're seeing is this red sort of dotted line is a target in terms of increase in access at about a 75% rate for individuals in the population. At the bottom, you can see that there are the racial ethnic categories, and I won't go through each of them, but just for comparison, the pink line is looking at white only, not Hispanic or Latino, and the purple line is looking at Black or African American individuals. Excuse me. And what you see in terms of comparison, that over the years, that there has been a significant gap in terms of Black individuals not being able to receive treatment in comparison to their counterparts. And although there was some spikes and increases over time in terms of treatment use, there still tends to be this gap in terms of increase in access comparable to other populations. And so one of the reasons that we really want to understand this as we sort of move forward is, given this, when people do come into our offices, how do we get them engaged to keep them in treatment so they can get the help that they need? Similarly, you'll see that comparing youth mental health treatment access, there's also a similar gap here. The colors change a little bit on this graph. The green line is looking at Black or African American youth. And again, you can see that there remains to be a gap in comparison to their counterparts. And although other populations, particularly looking at youth, have significantly increased access to treatment over the years, Black youth still tend to underutilize or have limited access to services compared to their counterparts. So again, this is really important for me. One, just understanding where these gaps are in terms of access to treatment, but also recognizing that when we do have individuals in our offices, that we want to do our best to try to address any potential barriers that may prevent them from maintaining engagement in treatment or resulting in an early termination or dropout. So I wanted to come back to my point that I made earlier in terms of why is it important to discuss Black and African American clients and what that means in terms of their identity. I think for a long time within the field that we've used Black and African American interchangeably for a variety of reasons. And also that sometimes we sort of use African American as a way to capture everyone that identifies within the Black community. And so for me, as I have begun to talk about this topic more and do presentations within communities and understand their own perceptions of their identity, it became important to me to have more discussions about why we as clinicians and therapists and even researchers need to do a better job in terms of how we understand the diversity within these communities. So there are a couple faces on this screen. Some of them you may know. They are all celebrities. And I sort of picked them out just to be able to distinguish their identities in terms of their cultural background and heritage. All of these people I would describe as Black, maybe Black American in terms of terminology. But I think even using that term can be challenging because they may not necessarily identify as American. And so in terms of heritage, just to sort of go through a couple of these, Usain Bolt, who is a track star, which is at the very top left of the screen, is actually Jamaican. And so if we, describe him as being African-American, let's say if he was our client, that may not fully capture how he describes his own cultural identity. And so we do want to be able to gather appropriate information to be able to distinguish what are those differences, but also have a better understanding about what may be some of the cultural aspects for that person that may be important in terms of working with them as a client. We can also see Barack Obama here, who has identified as biracial. Sometimes people overlook that piece and just sort of identify him as sort of the first Black president, for example. And again, there are some nuances with understanding these terms. And so I do want to highlight that today, just for us to be more mindful about how we capture that information, either through our intake process or when we're having some discussions clinically with our clients about their racial and ethnic identity. So what are the barriers to treatment use for diverse populations, and specifically thinking about Black and African American clients? So as I discussed earlier, there may be multiple factors that come up in terms of the literature. Some of these things you may have seen in your own work in terms of things that may have impacted individuals' access or engagement in the treatment process. And so I want to just highlight a couple of those things. Obviously, this list is not exhaustive, and that there may be other considerations to think about. But I think these are some of the ones that I've seen that may particularly be important to think about in terms of impacting access and engagement in treatment. The first one here is looking at mental health stigma. I think that this is an area that we have talked about for decades in terms of how having these negative perceptions about labels, for example, may prevent individuals from engaging in treatment. And what we see, particularly with Black clients, is that sometimes they may be avoiding of services because they don't want to get that label and be stigmatized either by others or to have some internalized stigma in terms of their own self-efficacy and their abilities to be successful in a number of areas in their life. And one thing that I've seen, particularly in my own work working with youth, is that sometimes when the child does have a diagnosis, even something like ADHD, that the parents may be reluctant to disclose that information to the school system because of the impact that that may have in terms of how they may be perceived in the classroom by the teacher, as opposed to really recognizing how that label and sharing that label with the school could be beneficial to getting appropriate accommodations in the classroom setting. So I think we have to really have some conversations sometimes about what it means to have a label and how that label helps us to communicate professionally in terms of this. Um, and hopefully that will help reduce some of the stigma that people feel in terms of that particular diagnosis that they may have. Another consideration that may impact treatment among Black clients is understanding or perceiving this idea about weakness and what that means to seeking therapy. So having some sense of being resilient or being able to manage challenges on your own may be something that is really important to individuals. And so the fact that they have to seek help may make it difficult for them to come into your office initially, but also to potentially, continually engage in their treatment over time. And I think if we think about some of the gender differences in how people are socialized, particularly males, that may be a really important consideration to discuss when they're in your office, to really understand like what role does masculinity norms in particular play in terms of their considerations about seeking treatment and how that may have changed for them once they actually begin to work with you. Another consideration is looking at mistrust or fear. And so this is an area that for me, I have begun to look at a little bit more over the last couple of years. I think historically, we have seen where there has been medical mistreatment of Black and African American individuals. And so that fear about working with a therapist also has translated over from some of the medical field. And people continually have some concerns about, can they trust a provider that they're working with? And I think this also shows up sometimes in terms of individuals being reluctant to maybe talk about some sensitive topics, such as, any type of abuse, so physical, sexual, et cetera. And partly that, I think, is sometimes when we see abuse, let's say physical abuse that's reported, that the way that that is handled in terms of racial differences between white clients is that it may be more likely that the child is removed from the home in a Black family as opposed to a white family. And so those are some things that I've seen in terms of my own work around things like reporting how that fear may contribute to their desire to maybe disclose certain information to us. Another consideration is looking at religion and spirituality. And so there is a lot of research that really talks about for individuals within the Black community that about 85 to 90% identify as being religious or spiritual. And if we look at that in comparison to therapists, we know that there's a gap or a difference in terms of therapists' identification with spirituality or religion. And so one, that's important because I think sometimes if we as clinicians don't identify as being religious and spiritual, that sometimes we may not have conversations about the importance of that with our clients. We may be uncomfortable discussing that particular topic, or we may not want to share our own faith with our client because we think that those differences may impact their ability to potentially engage with us in the therapy setting. We also know that, religion can play a role in terms of people's ability to cope with stressors, and particularly in the Black community, that individuals may prefer to seek out religious coping strategies, either through engaging in prayer themselves or to seeking out things like pastoral or spiritual counseling as sort of their primary source of support, which may then impact their engagement in working with us as clinicians. So just to share a little bit of data in relation to some of this, to sort of highlight some of the things that I discussed. This particular graph here is showing a paper that I published a couple of years ago, really trying to understand among parents, how do these differences in terms of attitudes and perceptions show up in comparison to other groups? And this was a sample of parents of preschool-age children trying to get a sense about what differences exist across racial groups, and also how does that impact their intentions to think about seeking out therapy. And basically what you're seeing here on this graph is that for Black parents, that they, in this particular study, reported significantly less positive attitudes compared to their counterparts, and also reported significantly more stigma. And again, just sort of reiterating that, thinking about some of these general barriers for individuals, that this is still something that has been a consideration. One thing that I'm curious about that I don't have data on right now is, what is the role of technology and social media in changing some of these perceptions? And so it's possible that, given sort of these increased conversations that we have in relation to mental health in public spaces, that this may have shifted a little bit. But I think anecdotally, at least in my own work, that there still remains to be some level of stigma within some individuals within the Black and African American community. Another thing in relation to the therapy fears that I discussed earlier was that this does play a significant role in terms of individuals' intentions to seek therapy. So this was a study that I published with some of my students, looking at college students and some of the differences in terms of their fears about going to therapy and how that related to their past use of services. And basically what you see on this graph is that individuals who reported not using services in the past endure significantly higher fears about going to therapy. And one of the things that we looked at, particularly with this data, in terms of understanding what are some of these fears that individuals may have, were related to engagement with the therapist, concerns about confidentiality and disclosing information, and also fearing how they may be treated by the therapist as well. So again, these are things that I think we want to be mindful of in our interactions with clients, to not sort of allow those things to impact our relationship, but also I think more importantly to have some very intentional conversations about their perceptions about how therapy can be helpful, and also how they see your relationship working with you, or experiences that they've had with past therapists. And so one way that I sort of check in with my own clients at sort of the initial couple of visits is really understanding, for those that have had therapy before, what that experience was like for them. And if there were things that they might have wanted to be different about that relationship with their previous therapist. And that allows me an opportunity to hear firsthand from them any potential negative experiences that they've had with their therapist that might potentially impact our working relationship. So I want to talk a little bit about sort of cultural competence and cultural sensitivity. And I think as a field, understanding the barriers that I just discussed, that some of these things we can play a role in sort of changing and shifting, and others we have less control over those, and how that may impact our relationship with our clients. One thing I think that we can play a much stronger role in having some control over is our ability to engage in treatment in a culturally sensitive manner. And so I think for me, understanding cultural sensitivity, cultural competency, and how that relates to therapy use is that we know from the literature that when clinicians are culturally sensitive, that it does address some of the disparities in treatment, particularly among African American and Black clients, and that it could help to reduce premature termination or discontinuation of services. So we want to be mindful about sort of what we're doing with respect to cultural competency, because the literature notes that it does help to increase the trustworthiness and the ability to be perceived as an expert by the client. It helps to impact the client's decisions around participating or terminating treatment. And it also impacts improvements in terms of treatment outcomes. And so all of those things we want to take into consideration. So what is involved in cultural sensitivity? Oftentimes when we look at this in terms of the literature, it is the person-oriented conceptualization of how we focus on our characteristics as a therapist in terms of our awareness of cultural differences, having an understanding about our own beliefs in culture and how that impacts our interactions with our clients. Excuse me. It impacts our ability to have a knowledge about the client's background. And obviously some of this we can get through reading or through trainings like this on cultural sensitivity. But another piece I think is how do we understand some of the nuances in those sort of broad cultural considerations by having dialogue with our clients about their own background. And that goes back to the point that I emphasized earlier in terms of how do we have conversations around ethnic and racial identity with our clients, which is, I think, a part of this knowledge about the client's background. And then being able to implement therapy in a culturally sensitive manner. So how do we make sure that if we're using evidence-based treatments, for example, that those treatments have been shown to be effective with clients. And I know that in theory, if it's evidence-based, it should work with all populations. But we also know that sometimes there may need to be some tailoring for these interventions to make sure that culture and the context with which the client lives is also taken into consideration with those treatments as well. So want to talk, excuse me, I want to talk a little bit about some of the APA Multicultural Guidelines. These you may already have been familiar with. If not, there's a link on the slide in a second that will show you how to access that on the web. I'm not going to read these principles verbatim, but I really want you to sort of get a sense about within the multicultural guidelines, there are a number of areas that need to be considered. And I believe there are about 10, if I'm not mistaken, guidelines total for us to really think about. One that I think is really important in relation to this topic today is how do we understand identity and self-identification in regards to clients, and that those things may be very complex. So connecting this back to terminology that I discussed before in terms of Black and African American, it really is important to get a sense from our clients about how they identify. And I think sometimes that is challenging because if we're using intake forms that allow clients to check off a box, it may not provide space or opportunity for them to disclose their preferred identity or how they would like to describe themselves. And so it is helpful to check in with them about that. And I'll try to come back to this later in relation to what may be some ways to do this. You also want to be aware of the role of social and physical environments. Obviously, as clinicians, we are mindful about context and how that impacts our clients and their functioning. And I think also understanding how these dynamics within the larger sort of social landscape could also impact our rapport and relationship with our clients. And as an example, one of the things that happened, I think, during the pandemic and after the killing of George Floyd was that a lot of Black clients who were previously working with non-Black clinicians begin to terminate those therapy sessions and try to find a provider that identified as Black or African American. And so I say that as an example of that, when there are complex issues in society or that there may be racial tensions in your community that may impact that therapeutic relationship and rapport with your clients, even though that may have been going really well, for weeks or months, those sort of shifts within society could impact their relationship in some way. And so we do want to be mindful about those things. Another one that I think is really important that I will talk a little bit about in a second is about the role of power, privilege, and oppression. And I think, as therapists, we talk about understanding these dynamics, in graduate school and obviously continuing in our professional life. But it is important to sort of recognize how that may show up in dynamics with our clients. A couple of other considerations in these guidelines are listed here. Again, not going through all of these verbatim, but one for me that's really important is how do we promote culturally adaptive interventions. And so again, connecting this back to this focus on evidence-based movement, that these treatments oftentimes are really effective. But if we look at the literature in terms of comparing evidence-based versus culturally adapted treatments, what we see is that there's improved outcomes when we use culturally adapted interventions. And so we do want to be mindful about that in the ways that are we using these interventions that have been sort of researched and culturally adapted, or are we making some modifications based upon sort of our clinical experiences or what the research says to maybe modify those evidence-based treatments in some ways to make sure that there is enhanced use with our clients. So just a brief example, in terms of my own work, I have used PCIT, or parent-child interaction therapy, in the past, which is an evidence-based treatment that works with young children, usually for me in my work with disruptive behavior disorders. It is a great treatment, but it also requires that families have a timeout room, that they do like this special time or homework with the individual child on a daily basis. And one of the challenges that I've seen sometimes, particularly with some families, is that if they don't have space in their home to have like a timeout room, then it's going to be really difficult for them to implement this intervention. And so there has to be some flexibility to modify those treatments so that you can still adhere to some of the structure of the intervention, but there is some room to adapt that based upon the client's cultural background and the context of the family. And then actively strive to take a strength-based approach. And for me, I think, as a field, we don't always, even though we try to understand strengths of our clients, I think that the way that we sometimes talk about clients, we don't always highlight what those strengths are. And it tends to be focused more on some of the negative experiences of our clients. So again, as I mentioned earlier, if you have not seen these guidelines or had a chance to review them, there's the link here on the slide that you can access it. You can also Google APA Multicultural Guidelines, and it should be able to take you to that, and probably one of the first things that pop up in the search. So I'm not going to go through this verbatim. There's a lot of stuff here. It's very busy. But I do think that it's important that we recognize in terms of the very center of this here that our role as a clinician and that of the client is a bidirectional relationship. And so things that we do influence our clients, and clients can also impact us in different ways. And one of the things that I oftentimes talk about, especially in trainings like this or with my students in the program where I teach, is that we can have some biases and perceptions about our clients, particularly in terms of their cultural, racial background or the community in which they live. But clients can also have perceptions about who we are as clinicians. And I think that we may not oftentimes think about, what are those biases that clients may have about us and how is that going to impact that relationship? And so I like to highlight that because I think that, sometimes clients can have those perceptions of you, whether you are a white clinician or even if you are a clinician from their own community, that they may have some perceptions about you as a person in terms of your identity or how they perceive you when they see you in person or in your office. The other thing that I want to sort of bring your attention to are these arrows on the side that focus on increasing resilience and reducing trauma. And I like to point those out because I think that sometimes the way that we engage with our clients, particularly in regards to cultural sensitivity, it actually may reduce resilience and it may increase trauma. And so we do want to be mindful about how we navigate, certain topics in the clinical room, particularly around race and racial differences, and how we talk about that. And I know that sometimes it's not an easy conversation to have with clients, but I think that that particular discussion can be had in a way that might actually lead to some additional challenges or re-traumatize the clients in terms of experiences that they've had in society. So a couple of guidelines here that I want to highlight with the rest of the time that we have. And I'm going to talk about a little bit of a case vignette. And so these are three guidelines that I wanted to sort of highlight a little bit in this case. One, psychologists endeavor to be aware of the role of the social and physical environment in the lives of clients. Guideline 5, psychologists aspire to recognize and understand historical and contemporary experiences with power, privilege, and oppression. And then guideline 10, psychologists actively strive to take a strength-based approach when working with individuals, families, groups, communities, organizations. So I'm hoping that in the case that I share, these things will sort of be highlighted a little bit as I sort of talk about it. So this is a vignette, again, as I mentioned earlier, about content being related to my book. I share this vignette in the book and talk about it a little bit in terms of how this relates to cultural sensitivity when working with Black families in particular. So this case describes Kimberly, who is an 8-year-old African-American girl that was referred to treatment by her parents. The family reported to the provider or therapist that they identify as African-American and occasionally have felt that they were mistreated due to their race. Kimberly's mother stated that she and her husband are very spiritual and inquired if the therapist believed in God. And so the parents also expressed during the session that they each identify with different religious faiths and that one in relation to a Muslim and the other one identified as Christian faith. And while the therapist was welcoming to the family in this session, the therapist was reluctant to disclose their own religious beliefs to the family. So as a result of this interaction and the therapist's avoidance of certain topics with the clients, particularly not discussing, perceptions about mistreatment, as well as the provider's sort of religious affiliation. The family did not return to follow-up appointments. And so thinking about this, and feel free to comment in the chat if you like, what may have been some other things that could have been done in this case to improve cultural sensitivity with the clients. And I'm going to highlight a couple of these in a second. Also, if you have questions, you can also post questions in relation to that using the Q&A box, and I can talk about those maybe at the end of today. So a couple of things to think about with this case and with Kimberly and her parents. For me, one, I think it is important to understand the role of intersectionality with this client. So as an African-American girl, and parents of an African-American girl, we do want to be mindful about how Black girls are perceived, particularly within the school setting. I didn't mention the specific referral question, but the parents were seeking treatment for some ADHD concerns. And so given some of the disparities in terms of discipline practices within the school setting, we want to sort of contextualize all of those things with our client, given what was presented to us. We also want to take some time to explore the mistreatment due to race. And so obviously this is a little bit vague in terms of the case. We don't know if that mistreatment was due to previous therapists that they worked with, if it was situations within the school or in their community. And so we do want to be able to explore that a little bit. And as I talked about earlier, that when we're in this particular environment, sometimes it may be uncomfortable having these conversations about racial differences, particularly if it relates to, if you're a white clinician working with a Black family, you may not want to, bring up those discussions. And so I think, for me, one of the things that I encourage people to do is, given some of the power differentials in setting, that you may want to, for you to set the stage around those conversations and let the client know that it's okay for us to talk about this. Because sometimes clients may be hesitant to sort of expand or bring up these issues because they're not sure how you may respond to that conversation. And so you do want to sort of take the lead and at least sort of bringing it up. There may not be issues, particularly as it relates to sort of the therapist, but I think that if you don't bring that up, then they may not sort of disclose that information to you. So I do think that you want to sort of talk about that. Another piece that I think is really important is how do we think about, or how do we talk about sort of religion and that being a sort of coping practices for them. So again, tying this back to the strength-based approach. I think, for me, as a therapist who identifies as Christian, I've actually had a scenario like this happen before. And early in my career, I was really reluctant to share that with clients, and oftentimes, did as we sort of learn in treatment to, process with clients, why is this important to you? And so I think like if a client brings it up, then it is something that is important. And so we want to sort of have some dialogue about that. And so now what I tend to do, it doesn't happen often, but if it does happen, I at least share with clients that, my approach to working with them is not going to be from a religious or spiritual perspective, because I'm not trying to integrate spirituality into psychotherapy. But I do encourage them and empower them to continue using those strength-based approaches that they see as important to them. And so I think it's important to have that discussion with our clients. The other piece is you can also decide if you want to disclose your own identity or not, in terms of your affiliation with religion. And while again, you may not be approaching treatment from that way, I think that if you at least can let clients know, like, you're comfortable having that conversation and that you're still okay with understanding how that's important in their life, I think that can still help to maintain rapport with the client. And so I sort of have talked about a couple of considerations in terms of understanding how you might apply some of these guidelines. Again, is not meant to be sort of exhaustive. And so just a couple of additional points to touch on as we sort of wrap up the last couple of minutes. Let's see, let's start here. So one thing that I think is really important in terms of considerations for working with Black and African American clients is really just understanding some of the sort of broader cultural differences in terms of sort of American society or Eurocentric values, and how that may differ from Afrocentric or West or values within the Black and African American culture. One, just to sort of distinguish between these two, I think that therapy oftentimes is very centered from a Eurocentric perspective, in that oftentimes we may emphasize individualism or the individual. And although we may have approaches that focus on, family systems and addressing those issues, I think that even when we're working with clients on a one-on-one individual basis, we also want to recognize the role of the group or the family for that client. And oftentimes what the literature sort of highlights is that for Black clients, even on this sort of individual basis, their individual behaviors and actions may also connect back to how does that impact the broader family unit. And so we want to recognize that from our clients and connect that to the work that we're doing as well. Another piece that I think is really important to think about is that therapy oftentimes is very future oriented and not necessarily focused on the here and now. And one example of that for me is that when we think about therapy and sort of what that looks like and what that process is like, that oftentimes we set these short or long-term goals that require us to meet and work with clients for several weeks before we begin to specifically work on some skill, for example, to help them cope or manage the challenge that they may be presented to deal with. And while I understand the purpose of that, I also recognize that for some Black clients that it takes a lot for them to work up to coming into treatment. And so if they come to that, first or second appointment, and all that they're doing is sharing information with you and information gathering, and they don't feel like they sort of got a tool or something to help them reduce some of the stress that they may be experiencing in that moment, that also may play a role in them discontinuing treatment early. And so we do want to be mindful about that, because they may not see the benefit in therapy initially. And so if they're not benefiting from it, it can impact that working relationship. And so I oftentimes encourage people to think about ways that you can focus on sort of future short or long-term goals, but also making sure that clients are able to be empowered within the first couple of sessions as well, to see that there are things that this is helping them with in the here and now, and that's going to be able to continue over weeks and months as they continue to work with you. And then another thing that I really want to point out as I sort of jump around the slide is this idea about how we focus on eye contact in terms of understanding clients' engagement. And so there's a lot of literature that talks about how for Black and African American clients, that they may be misdiagnosed or overdiagnosed with more severe types of conditions due to how eye contact is perceived by the clinicians. And so what we oftentimes see is that there may be less eye contact when clients are listening to you. And so you don't want to misinterpret that as, let's say, responding to some type of internal stimuli, when that just may be sort of that cultural nature of engaging. And so we want to be mindful about how do we distinguish between, if someone is experiencing some type of psychosis, as opposed to if they are just sort of engaging with you in a manner that is typical based upon their culture. A couple of additional points to think about. And so one is gauging the client's acculturation and ethnic identity. I think that we don't oftentimes think about the importance of this when working with Black clients, and that it oftentimes is something that we think about with other populations. If we think about Latinx or Latino clients, or those that identify as Asian, Asian American, but not so much thinking about what is the role of acculturation and ethnic identity for Black clients. And I think that, again, that's important, particularly given that when we lump sort of Black clients as a group, that there may be multiple cultural heritage that are represented. And we do want to be mindful about that in the role that it plays in the client's life. Be willing to discuss racial differences. I think this is particularly important if you are a non-Black clinician or a white clinician and you're working with a Black client, that you do have some open dialogue about that. And one example that I oftentimes encourage people to do is asking questions of the client initially about, you know, how do they feel about working with you given your racial background or racial identity. And I think that again, one, provides a space to clients to let them know that this is not a sort of taboo topic to talk about, but also it provides a space for clients to share that if there is some hesitance about working with you, or if they've had hesitance in the past about working with a clinician who was not Black, that they can sort of share that information with you. And again, that could potentially help rapport. Focus on the client's everyday experiences. And this connects back to the here and now piece that I discussed earlier. And then finally here, identify what the client wants to work on in therapy. And all those goals consistent with their worldview. And I think, although we oftentimes talk about clients' goals and why they are coming to therapy, I think we also want to make sure that when we identify what those sort of treatment goals are in terms of our treatment plan, that also is connected to really what the client wants to work on. And so having some discussions about that. I'm not sure about your approach in therapy about, you know, do clients get to see the treatment plan, or is it something that you try to keep individually in your notes? And there is variability in terms of now that more people are using sort of EHR systems, that they actually share those treatment goals with the client, and the client also signs off on those treatment goals. And so that may be something to consider in your work that you're doing as well. So just in summary, you know, what we know is that Black and African American clients are typically less likely to use treatment, and that there are a number of barriers that may impact that, and that we want to be mindful about how do we address some of those barriers, and particularly how do we think about you know, cultural sensitivity to try to address some of the systemic and environmental barriers that may show up in our working relationship with our clients. And finally, cultural sensitivity is extremely important, not just in the work that we do, but also in terms of research, and making sure that in research settings that we are adequately assessing, let's say, ethnic and racial identity of our clients as part of that process, and understanding participants. So I'll open it up for questions, if there are any questions. These are just some additional resources here. This book, Eliminating Race-Based Mental Health Disparities, covers a lot of different things. One of the things that I think is really relevant is there's a chapter that talks about how do you deal with issues around race and racism with clients, and how do you address that topic, which I think can be really helpful. Also, for people who may be in training settings, I recently worked with APA to produce this psychotherapy training video, which shows a case of working with a male client, and then we sort of break down what are some of the cultural issues that show up with that particular client, and understanding intersectionality that also shows up in terms of some of the gender and sexual orientation challenges that may come up with clients as well. So I will open it up. If there are questions, I can share in the, I guess, a minute or so that are left. This is my contact information. If you do have additional questions for me, also if you want access to the slides, you can scan this QR code here, and it should take you to my website where you can download a handout of the slides from today.
Thank you so much, Dr. Turner. I did want to just hop in with a quick question. As we're discussing the disparity in access to treatment and the role of different community-based, as Black and African American clients may turn more to their community, how might a clinician partner with community organizations or religious affiliations to kind of increase that access? Or is there any outreach that one might be able to do that you would recommend?
Yeah, no, that's a great question. I definitely think that's important. And one of the things that I talk about with my students in our training program here is that you want to get a sense about what are those community-based resources. So once you locate to that community, because you may not initially know. So I think having that like resource list can be really helpful so that if clients do bring up things and are looking for sources, let's say they just relocated to your city, religion is important to them, but they don't really know where to go. So you might have a list of these are some possible churches in the area, for example, that may be a source of refuge for you. So I do think that's helpful. Another piece I think is trying to get out in the community and do some free talks, at schools or churches, et cetera, just to provide some psychoeducation about these issues. I think that can address some of the potential stigma that may exist around services, but also provide that way that people can connect with you as well and see you as a resource.
I think that makes sense. You did talk a little bit about the importance of family. I was wondering if there was an increased emphasis on working with Black or African American parents if you do have a younger child clinician or child that you're working with, or if you focus more on the child and kind of go business as normal.
Yeah, I'm glad you asked that question. That's a really good question. I try to do one, if it's a child that's under 10, parents are typically very involved in my sessions. But even if I'm not doing some sort of parent training type of work, I try to make sure that parents are involved in terms of understanding what's going on with the client, the treatment, et cetera. Because what I've learned in my experience is that, for some families, they feel like they bring their kids to therapy, particularly younger children, and they don't know what's going on. They never get a chance to come into the sessions with the therapist and the child, and they are completely disconnected from what's going on. And so I do think that it is important that you get them engaged in the treatment, not just sort of sharing what the goals are, but also making sure that they understand what's going on, like what did you work on today. Those types of things might be helpful to get families included as well.
Yeah, I think that makes sense. I'm going to just give you one more question, and then we'd love to be able to reach out if we have any additional ones. We do know that mental health research and clinical research has been skewed Eurocentric over the times. I was wondering if when someone has a Black or African American client, if they should think about symptoms and behaviors a little differently other than the ones that may have been clinically research based on maybe a white audience.
Yeah, absolutely. I think that's definitely important. And one of the things that I've seen too, like we use screening measures, and sometimes those may not be the best ways to assess for symptoms in our clients. So one example, just briefly, I know time is wrapping up, is screening for anxiety, for example, in Black youth. And what some of the research has shown that has looked at that is that may look different. Like symptoms may look different in Black kids in terms of anxiety. And so you may actually miss diagnosing them with anxiety because the screening measures don't ask the appropriate questions. And what that structure looks like in terms of the items are different. And so we want to be mindful about, if we're using, some structure type of screening measures, that we examine the psychometrics of those measures in the population, and especially, the population if you're working with Black clients.
Yeah, Thank you so much. I want to thank all of our attendees for joining us today. I want to thank Dr. Turner for his education. If you are not currently an ADA member, we invite you to join. ADA members get free access to CEs and webinars such as this one. We'd also like to invite everyone to our upcoming conference in April in DC, where we have a great collection of presentations, symposiums, and student posters. Thank you everyone for joining us today. Dr. Turner, thank you for your expertise.
Thank you so much. Take care.